So, Nirmish, let's talk about hydroxyurea. So, that's the first FDA-approved drug for sickle cell disease, and it's been around for a while. And unfortunately, the uptake has been kind of poor. So, can you share with us how does hydroxyurea work for sickle cell disease? What is the efficacy, and what do you think are the challenges of using hydroxyurea?
Yeah, so I think we have quite a bit of literature now on hydroxyurea because it's been approved for quite a bit of time now. And what we have learned is that, number one, the reason it works so well is that it does a couple things. And to begin with, the mechanism of action starts by basically essentially tricking the bone marrow to make more fetal hemoglobin. And fetal hemoglobin is baby blood. And as we talked about earlier, where the issue with sickle cell is polymerization, right? The hemoglobins are stacking on themselves, stretching out the cells to become sickled. But when you insert more fetal hemoglobin, which, as we'll probably talk about a little bit later, shifts the oxygen curve, dissociation curve to the left a little bit, you hold on to oxygen a little bit more tightly, and oxygen is protective because there's more blood cells that have this fetal hemoglobin as a higher ratio and have less sickling. In addition to the effects on the fetal hemoglobin, which we do monitor quite closely, we also look at the fact that it's myelosuppressive, meaning it decreases all your blood cells, your white blood cells, your platelets, and it slows down your reticulocytes, so the reticulocytosis. And that is something that we have to monitor. So that's why we ask our patients to come in every 3 months, 1 to 3 months, depending on the schedule. But we have to be also aware that that is helpful. So we actually want to titrate the dose to what we call maximum tolerated dose. We titrate it so that we do have some of that effect, because white blood cells have adhesive proteins. Platelets have adhesive proteins. They're activated and sticky. And so all those, again, as I tell my kids in my clinic, all the sticky stuff sticks together, and we don't want to do that. So we decrease with this hydroxyurea that effect.
Okay. And so when you give somebody hydroxyurea, you say you want to titrate to maximum tolerated dose. We've seen a lot of patients who say hydroxyurea doesn't work for them. What has been your common experience as to why hydroxyurea is ineffective in some patients?
Yeah, so I'm going to go ahead and just say it. When a patient tells me that it's not working, the first thing I have to ask is, are you really taking it every single day? And I think that goes back to something that you had asked me and I didn't completely answer, which was that compliance is a huge problem. And I think that there's a large amount of literature to support that our patients, no matter how you look at it, mean possession ratio or otherwise, are not filling the scripts, even when we give it to them.
But there's reasons, right? Not to completely interrupt you.
No,
but
absolutely.
I think patients do have some concerns. I think one thing that's really important I've learned is telling the patients why we give it to them.
Absolutely.
And explaining what it is. So, I explain what it is and exactly what it does, because sometimes I've heard that that's not always explained to them.
Yeah, and I think I feel like I'm a broken record here, but if you don't ask, why are you not taking it? Not just saying, well, then just make sure you start taking it every single day. And ask, well, what is it that you're concerned about? That's exactly right. And then you have some patients like, well, I'm just worried that I'm going to lose my hair or it's going to cause cancer. These are all things that you have to have education about to try and make them understand. These are the risks that may be real with patchy hair loss or leg ulcers, but a very small minority actually have those. But the benefit, again, if you take it consistently, if I can get to a point where I can titrate it to a maximum tolerated dose, then I have a chance to have a clinical benefit. I do think that in context, having patients understand that this takes weeks to months to really
it's
kick in.
It's not a quick fix.
So it's not something that you take today and you're going to feel better
tomorrow.
tomorrow.
Not a pain medication.
Exactly, yeah. No,
And you can't just take it when you have pain either.
Yes.
Right? Like you really have to take it consistently.
Yep, absolutely.
And that can be hard too, because it can be 2 to 3 pills a day, sometimes 4 pills a day. And there's a lot of pill burden that patients have to contend with when they have chronic disease.
Exactly.
And so, Matt, with the hydroxyurea story, right? So for children, we calculate medicines by milligram per kilogram per day. Sorry, milligram per kilogram per day. When you get to adult care, we typically calculate medicines by a standardized dose. So have you noticed that as your young patients get older, that their effectiveness of the hydroxyurea changes? And what do you think is the reason behind that?
Well, I think hydroxyurea, its effect is on stressing the bone marrow, and that's what leads at least to the fetal hemoglobin induction. And I think that the bone marrow, much like any other organ in a patient with sickle cell disease, gets affected and damaged over time. And I think that if you wait until adulthood to start hydroxyurea, that organ, the bone marrow, may be damaged and may not make as much fetal hemoglobin if you delay in the starting of it. I think that's one idea that potentially could cause that. I think there is building evidence that and the NIH has recommended offering hydroxyurea to children at 9 months of age, regardless of their clinical severity. And as we're seeing this moving forward, it seems that we can induce a higher fetal hemoglobin, which appears to be long-lasting, and then protect not only the bone marrow as an organ, but the other organs, hopefully to get them to adulthood in better shape that will allow the persistence of the benefit of the hydroxyurea.
And so, Beret, I've seen a lot of adults who come in and they're on 1 pill a day for the past 5 years, and that it doesn't work for me, Dr. Iffy. It doesn't work. I'm not going to take it anymore. What do you tell your patients when you see that?
Well, first of all, I talk to them about the concept of driving the dose as high as possible to get the maximal benefit. And data have shown us that if you can get people to a maximal tolerated dose, you'll improve efficacy. And the efficacy we're looking for here is a reduction in the frequency of pain crises, and hopefully some effect on chronic organ damage over time at a minimum. So that's what I do. This is not uncommon, particularly when I see patients who've been in the community for a while, being seen by someone who's maybe not as familiar with sickle cell disease. They're often on 1 pill a day, 500 milligrams, but as we begin to titrate up, they do oftentimes see improvement not only in their fetal hemoglobin level, but more importantly in the frequency of pain crises.
And I think this concept of maximally tolerated dose is extremely important, and you were asking me about how we dose the medication, and we dose it until we see myelosuppression, and the ANC is in a goal range of about 1,500 to 3,000, and that ensures that you're getting enough of the medication, hopefully without significant toxicity. And that really has shown to maximize the amount of fetal hemoglobin induction. It's also quite clear, however, that the white blood cells are involved in the pathophysiology and that vaso-occlusive event. And so even though we might consider it as a toxicity or a side effect of hydroxyurea therapy, by suppressing the neutrophil count, it's actually probably a benefit as long as you don't go too far.
Okay. Yeah, the other thing is that as people gain weight, their dose may change. As they go through puberty or menopause, their dose may go up or down. And so it's important to have them see their provider on a regular basis. No later than 3 months is usually recommended, so that you can kind of monitor these changes. If they have a myelosuppression, you got to titrate down. When they're doing well, you may titrate up to get the MTD. And so it's important to have that close follow-up. Ask the right questions, look for and seek out, are you having any complications? Because if you don't ask about complications, they're going to think you don't care, and they're not going to tell you. And they'll suffer in silence.
And I would add that, I think, again, going to this idea of making sure we're communicating with the other providers
Absolutely.
while they're on hydroxyurea.
Yes.
For example, we have patients that go into the hospital or admitted, let's say even to a community hospital, for example, and they feel like they're in pain, so they need to stop the hydroxyurea. And that may be the case depending on the blood counts, but it's a conversation that I think is not always understood, that this is a long-term type medication.
Absolutely.
And that the acute situation needs to be reassessed. So I think we need to make sure we're communicating with our providers as well.
And you know what? Similarly, it's really important that they don't start hydroxyurea in the hospital.
Yes.
We really want to make sure that providers have a relationship with patients, because if you just give it to them, you're only going to see them for 3 days, you're going to go off service. They don't know you, they don't trust you. Exactly. But also, what if you send them home with hydroxyurea and no one is going to follow their labs? Because there is a risk, and especially as patients get older, we really need to watch a little bit more closely, because sometimes we do, as patients get significantly older, need to titrate down that dose.
Yes. With renal disease, and as their bone marrow may get exhausted, or they may have a viral infection that suppresses their bone marrow. So those are important nuances to kind of pay attention to.